Hello and welcome at London Valves 2023. I'm Philipp Lurz and I'm joined here today by Julien Dreyfus and also Lenard Conradi. We would like to discuss a little bit the latest developments in the field of treating tricuspid regurgitation. Obviously very active field, a lot of new data we have seen here and many new innovations. What's important for you when thinking about treating TEER?
Well, I think first of all I would think about the disease status. Where is the patient, that individual patient, in terms of disease progression? Because I think at present, considering surgical interventional therapies, we have a complementary therapeutic field, right? Surgeons, I think, should appreciate tricuspid valve disease more and in its earlier states, whereas at least at present, interventional therapies probably are best, located in the late disease states. Now that is a snapshot today. We don't really know where it's going, but this is how I would approach it at present. I
think that's important because obviously interventions, they can also stimulate a little bit the surgical field, and we talk about the disease much more and also surgical solutions as well. Absolutely.
And we're responsible for at least a part of the procedure of the patients that end up with end-stage tricuspid disease, not only the surgeons, but the heart teams, because we have, not considered TEER enough, I think.
Julien, when thinking about different treatment options, what's important for you? How do you prioritize?
I think that what I've said, Leon, is perfect because we have to refer patients earlier, and then you have to state, I would say, 2 points. The first point is what is my surgical risk, and the TRISCORE may be an interesting tool to assess this risk. And the second point is, can I perform a transcatheter intervention? Is my patient suitable to predict an excellent result? And then we'll have to find a balance between the surgical risk and the suitability for a transcatheter intervention.
TEER has been around for a little bit longer. We now also have the possibility to do valve replacement, given the fact that the EVOQUE valve is now approved. How do you see that, TEER as opposed to replacement?
In fact, I like to make a comparison with surgery. If we look at registry for isolated tricuspid valve surgery, 2/3 of patients are replacement. So we could imagine that there is a place for both repair and replacement. I don't know exactly the proportion, but probably there is a place for both. But what for me is the most important thing is that at the end of the intervention, we should get an optimal result. And an optimal result is not the number of clips that are implanted, it is residual TEER. And residual TEER should be as low as possible. It is an important message. And transcatheter allows us to abolish TEER, while it's not yet the case for transcatheter edge-to-edge repair.
Yes, I agree completely. I think within the field of interventions, these should be at least at present complementary. I have to say I'm impressed by both the successes, the early successes of tricuspid interventions and the speed at which the field is evolving. I'm sure this has to do with maybe a comparatively lower degree of complexity of anatomical conditions compared to the mitral valve, for example. It probably also has to do with hemodynamics, which are, of course, profoundly different on the right side of the heart, and maybe in the high pressure situation of the mitral valve are a little more demanding, but nonetheless, I think this is a very, very interesting field. And as you said in the beginning, it's not only that this interest drives innovation in intervention, but it also drives surgeons to direct their attention finally at the early disease stages of tricuspid.
Yeah, fantastic. I think there's no doubt that with replacement we can treat more patients who cannot benefit from TEER, but at the same time there are a couple of things we still need to learn, how to deal with RV function, bleeding, maybe valve thrombosis. We hope that we can also learn from the surgical experience, because you have experience with valve replacement for decades, so that will be quite interesting. Now I'd like to ask you to give a bit of a perspective and glimpse into the future. Julien, what do you think in 5 years from now? What would be the predominant way of treating TEER? Surgery, TEER, or transcatheter replacement?
I think I would answer both. Because, if you are discussing with surgeons, there were a lot of debates for aortic valve, for mitral valve, but for tricuspid valve, they are not used to have patients refer to them. So when you send patients, they are quite surprised. So they are not looking for those patients, and now more and more they are performing intervention, because we say, hey, the patient has a low TRISCORE, the anatomy is not perfect for transcatheter, would you operate this patient? Right. And the operation is perfect, the result is perfect, and everyone is happy. So I would say that we will treat, and I hope so, we'll treat more and more patients, we'll treat patients earlier, and probably there will be repair, there will be replacement, there will be surgical repair, surgical replacement, and transcatheter repair and replacement.
So I'll ask the surgeon, what do you think will be the predominant transcatheter approach, TEER or replacement?
At present, I would put my bets on TEER. As I said, it is a little counterintuitive because you're directing a leaflet addressing therapy towards more or less an annular/ventricular disease, but the success I think speaks for itself, and I'm impressed by the way that you guys titrate TR down from the commissure, coming from the commissure as far as I understand, and adjusting it, maybe even with regard to afterload considerations, to right ventricular functional parameters, pulmonary pressure situation, and so forth. So I think TEER is a strong player. The whole field of valve replacement seems promising, but there are a lot of things to be dealt with. Anticoagulation is a big topic, I think. Conduction disturbance is a big topic. And of course, the devices and the systems are not very mature at the present state.
It's always difficult to make predictions about the future, but what we can say already now is that we are in a very comfortable situation, that we have new devices coming in, we have new options for our patients, and obviously we'll continue the discussion. And this is very important, there are multiple trials being conducted, so we will get much more evidence in the very near future. Thank you.